Hello everyone. So we have a 4-year-old boy. He's brought to you for evaluation of a rash. His mother states the pinpoint bruises have appeared all over his body during the past 24 hours. There's no bleeding or recent trauma. 3 weeks ago, he had an upper respiratory tract infection that was resolved uneventfully. He takes no medication, no family history of bleeding and clotting. There are scattered petechiae on the trunk and extremities, and the oral mucosa appears normal. There's no lymphadenopathy, no splenomegaly. Lab reports are hemoglobin normal. Platelet count reduced, leukocyte count is normal. That means there's only platelet count is reduced. Peripheral smear shows few platelets. The platelets are of normal size and morphology. With the best next step in the management of this patient? The answer to this question is, well, before we discuss the answer, let me tell you some of the keywords. These isolated thrombocytopenia, as we have seen in the lab reports, petechiae, no lymph node, no spleen, and URTI 3 weeks before. With this, the answer to this question is observation. Why is this answer? So first, this is a case of ITP. Okay, immune thrombocytopenic purpura. But let's learn some basic concept about immune. Thrombocytopenic purpura. Okay. There are platelet autoantibodies. Remember, it is an autoimmune disease. AI is autoimmune disease. So they have antibodies against the platelet. And it is usually predisposed by preceding viral infection. The clinically patient may come with petechiae, ecchymosis, mucosal bleeding, epistaxis or hematuria can be there. Lab report isolated thrombocytopenia, giant platelet are seen in some cases. And few platelet are normal or large, as I told you, that is giant platelets. Investigation, giant platelet are seen, like in this case, you are getting a big platelet. Management, the disease is usually self-limiting, okay, within a few weeks. So observation, if cutaneous symptom only, like in our case, the patient has only cutaneous feature, there is no other problem. Drug therapy, prednisolone is the best initial treatment. It decreases antibody formation. Then we can use intravenous anti-DRH immunoglobulins. High dose immunoglobulin therapy, it is the fastest way to act in acute and severe bleeding. But in our case, the patient has very minimal bleeding, so this is not to be used. Now, I have a question for you. Stop the video, write down the answer. It should not be given to which patients? Okay, which patient of ITP to be more precise? Well, the answer is it should not be given in Rh negative patients. Rituximab is a newer drug. We give not responding to prednisolone or IV immunoglobulin. So this is not the first line treatment, it is the third online treatment because it is a very expensive drug. Well, splenectomy is done in some selected cases because it itself has a lot of complication. So not a routine, but only selected cases. And then we can give certain drug which are used if ITP reoccurs after splenectomy. Then we can do thrombopoietin receptor agonist. Okay, the drugs are there. Used for refractory ITP. Romiplostin is given subcutaneous and L-trombopag is given orally. They are thrombopoietic TPO agonist drug. Okay. Now, patient in our question has ITP, How can we say the most common occurs in 2 to 5 years? Our patient is a 4-year-old boy. It's characterized by abnormality in low platelet count, like in our case, isolated thrombocytopenia is there. We usually call thrombocytopenia when the platelet count is less than 100,000 per cubic millimeter. Our patient has the count of 40,000 per cubic millimeter. That means thrombocytopenia is there. And this is due to this reason, increased tendency for bruising and bleeding. Like our patient has pinpoint bruise have appeared all over body in the last 24 hours, and for this reason only the mother brought the child to you. But in severe cases, patient may have mucosal bleeding, epistaxis, hematuria, GI bleeding can occur, but it is severe disease. Well, in this, as I told you, autoantibodies are there. They are directed against the platelet membrane antigen, and that lead to anti-antibody reaction, and that lead to destruction of the body platelet. Okay, and these are destroyed in the spleen. The antibody platelet complex which are formed because of union of platelet and antibody, and they are destroyed in the spleen. ITP is usually preceded by viral infection. In our case also, 3 weeks ago, he had an upper respiratory infection that resolved uneventfully. That means the patient had a viral infection, which is a self-limiting condition. Lab shows isolated thrombocytopenia and fewer variable size, normal to large. Although in our case, the count is low, but the platelet morphology is not changed. The hemoglobin is normal, TLC count is normal, and peripheral smear shows low platelet count, which we have seen in the actual platelet count also. So it means we are having only isolated thrombocytopenia, the point which I mentioned previously also. So as in summary, patient has only skin problem, so you have just go for observation, nothing else to be done. Okay, you keep on, and it's a self-limiting condition. In a few days it will get off resolved, so no need to use steroid or any other things. Self-limiting within next 3 months this will be totally resolved. Now what about option A, bone marrow? Bone marrow evaluation is performed if presentation is concerning for leukemia, but there is no finding of leukemia at all. Biopsy is not typically indicated for isolated thrombocytopenia. Now I have got a question for you. Which type of leukemia, leukopenia can happen? Normally in leukemia, TLC count is usually very, very high. But the question is, in which type of leukemia the TLC count may be reduced? The answer is subleukemic leukemia and hairy cell leukemia. In these two, the TLC count is reduced. In this, in fact, there can be pancytopenia. Okay. Option B, intravenous antibiotic. Antibiotic we use to treat sepsis, and this can lead to bleeding and thrombocytopenia from DIC. However, DIC are ill-appearing, having bleeding all over the body and hematuria, rectal bleeding, and they have a schistocyte on peripheral smear. They are really, really very ill. They are to be managed in intensive care, not in a OPD base. Okay, so antibiotics are not indicated in ITP at all. Platelet transfusion is treated for congenital platelet abnormality like Bernard-Soler syndrome, which present as a very large platelet on peripheral smear, and there is not a, now platelet transfusion is not a treatment of ITP. But now I have a question for you. Stop the video, write down the answer. The question is, what is the basic defect of Bernard-Soler syndrome? Okay, the answer is, this is the endothelium, this is the platelet, and this is the von Willebrand factor. Okay, and this they get attached to GP1A/9 receptor. This is normal whenever platelet plug has to be formed. In this patient, this is defective. With the result, the platelet plug formation will not happen. Formation will not be there. Okay. Right? So there's a defect in the platelets. That's why we want to give transfused platelet, so that whenever a plug has to need to be formed, we are putting a fresh platelets to help in this plug formation. Golden line to remember: ITP present with isolated thrombocytopenia after a viral infection. Children with isolated cutaneous symptom, petechiae usually recover spontaneously, require observation alone, regardless of the platelet count. Those with bleeding should receive steroid, anti-D, or intravenous anti-D intravenous immunoglobulin should be given to this patient. Otherwise, no need to give any medication if only cutaneous manifestations are there. Thank you very much.